Thank you, Winston. Thank you. Well, thank you very much, Winston. It's a great pleasure to be here. I should have put my hand up. I'm a first-timer at this meeting as well. What I'm going to do in the next 45 minutes is sort of touch on what I think are the big changes happening in prostate cancer related to imaging. I look forward to interacting with you after the presentation as well. So I thought I'd start by just recapping the lay of the land in prostate cancer and how it's worked up and treated today without the imaging part, because the imaging really is brand new and its introduction into standard of care is so new that it's really not being widely used as yet, I would say, in Canada and in Ontario. So let's start out by asking ourselves, well, we know prostate cancer is a high prevalence disease. Why do I need my prostate? If it's like the appendix, it's there, and I have a diagnosis of prostate cancer, maybe it's low risk prostate cancer, why don't I just have it out? Why don't we just go to the surgeons and all have a prostatectomy? The problem is that these whole gland treatments have a history of some side effects, and these are things that really can affect quality of life for men. So sexual dysfunction is the biggest one. There's urinary dysfunction and bowel continence problems, particularly with certain types of radiation treatment. And so it's not a treatment that we take lightly, and we have to be careful about when patients are recommended to go on to prostatectomy or whole gland radiation therapy. We know from many decades of experience now with prostate surface antigen, or PSA, as a screening test, that most men who get diagnosed with prostate cancer using PSA screening don't die of the disease. They die with the disease. So it's not a lethal disease for the vast majority of men. And this has actually led to a point, and for all of you that know this, when you've gone to your family doctor and say, I'd like to get a PSA test, he says, well, okay, discusses the pros and cons, he or she says that, and then you go on to having to pay for the test because it's not recommended as a screening test. And this is both the American and Canadian task forces on this have come forward and said, well, PSA is not a good screening test. It hasn't proven itself. And so we're kind of faced with this conundrum. Well, how are we going to diagnose prostate cancer if PSA is not recommended and we're left with the digital rectal exam, and all of us men over 50 probably had one of those. Not the greatest test for finding a cancer. And where does that leave us? I think it's established that the way we're going to make decisions about this is we need to be able to prognosticate, and that's what I mean by that is that we need to be able to tell for each individual man what the likelihood or risk is of them having a clinically significant prostate cancer. One is that is going to affect their life during their life expectancy. Are you at very low risk of having a clinically significant cancer? Are you at low risk? Are you at intermediate risk, high risk, or very high risk? And how do we figure out that risk when you come and see your doctor? And really the dividing line for intervening with treatment is between this low risk category and these intermediate and high risk categories. So it's really, this is a big deal. How are we going to risk stratify? Well, we know, again, from decades of research and long-term follow-up of men, more than 15 years, that when you look at a prostate that's been taken out and you look at it with pathology, so they look at it under the microscope, they are able to actually score the cancer on a scale called the Gleason scoring scale, and anything that's higher than a 7 out of 10, 7 or higher out of 10, is a clinically significant cancer. If it's a large cancer, has a big volume, more than half a cc, we worry about it. And if it's spread outside the prostate, we worry about it. The problem is to actually figure out this risk stratification, you got to take the prostate out. So, a bit of a catch-22 here. How are we going to really get an idea of these prognostic or risk factors without taking the prostate out? So we go to a paradigm now of, okay, we still kind of need the PSA test, so we're going to do something with PSA, and we're going to have to biopsy the gland. We're going to have to sample the prostate gland to find out what that pathologic score is, that Gleason score is, and how big the cancer is, without taking the prostate out. And the types of treatment that are currently offered include things like active surveillance. This is where you have a low-risk cancer and you're sort of watched by your urologist or your doctor closely with repeated PSA tests and examinations and biopsies. And you can certainly have various forms of radiation therapy, you can have a robotic or laparoscopic prostatectomy, and there's certainly a lot of research in image-guided treatment, and I'll touch on that. But is our risk stratification with this approach accurate enough? And the short answer is no. The type of risk assessment that we're giving you doesn't tell you whether you're going to die of prostate cancer or not. All you want to know, all I would want to know is, okay, my PSA is up, I just had a prostate biopsy, do I need to do something about this today? Is this going to kill me? Is this diagnosis of cancer going to kill me? I don't want to know that I have a 73% chance that it might kill me based on a large population study. I want to know, what does it mean for me? And that's what we need to achieve, and that's what we're all working for. So, if we look at what happens now, this is just a flow diagram, and we get the PSA test over here. If it's high, we go on to a transrectal ultrasound biopsy. How many people here have had a biopsy? Okay, so I don't have to tell you what that feels like. So they all go on to get a biopsy. Now, if the biopsy shows a significant cancer, it's definitely a high-grade cancer, that's straightforward. You're going to go on to some form of treatment, and you're going to get classified as somewhere between intermediate and high risk, and you're going to go on. Where you are on that scale, again, we need to do better, but you're going to go on. Something's going to get done. But if the biopsy is negative, or it shows an insignificant cancer, you end up back over here. You got to get another PSA, and you're just worrying about your PSAs over and over and over again. You might need more and more biopsies, and this just keeps going on in this loop until you either find something or you just get so fed up that you say, just take my prostate out. I can't take this anymore. I know I got a low-grade cancer, but I just can't deal with the anxiety. And that actually happens to a significant number of patients who get stuck with a low-risk disease but keep doing this. And then on top of that, when we look at what happens, we say, you know, most cancers in the body, most solid tumors, we actually make a diagnosis because we can see the tumor and put a needle in it. So if you have a colon cancer, someone goes in with a scope and is able to see the tumor and put a needle in it. If you have a lung cancer, someone sees it on a CT scan or a chest x-ray, is able to put a needle in the tumor and make the diagnosis. This is one of the few, if only, solid tumors, cancers in the body where we can't see the tumor very well with ultrasound. And so what the urologist does is he sticks in 12 needles into the prostate in a systematic fashion, typically 6 on one side and 6 on the other, in a systematic pattern like that. So the back part is where your rectum is, puts the probe into the rectum, and then biopsies the back part of the prostate because that's where most of the cancers are, all of them. And this obviously has a problem, is that even though it's 12 needles and it seems like a lot, you're actually only sampling a very small portion of the whole gland. And this picks up about 60% to 70% of the clinically significant cancers, but it's missing a lot of them. So we can't really see these tumors very well. This is a big problem. And we actually have blind areas, and you can see where they would be. They're in the front of the gland, at the bottom and top of the gland, where the needles don't easily reach. They're not long enough, or it would mean doing twice as many biopsies. That's a lot of biopsies. And then on top of that, as we get into the antibiotic era and antibiotics being used more and more, we're finding more and more men are getting infections after these biopsies. And so who've had the biopsies have had antibiotic prophylaxis. It's worse actually for doctors because we work and healthcare professionals. We work in hospitals where there's a lot of antibiotic-resistant bacteria. I worry about it when I need my prostate biopsy. So we really want to minimize the amount of biopsies that we're doing. We don't want people to go in with infections and things. I don't want to scare you about biopsy. It's a good test, but you know, we need to do better. So on the left is what we're doing now. On the right is kind of where we want to be. We want to be able to see the tumors, see the bad areas of the tumors, and direct our needles right into the cancer. How can we do that? So I don't know if we can have the lights down a little bit, or if just so we can see these images a little bit, but if that's not possible, that's okay. What was noticed about 10 years ago as we started to look at prostate MR images is that there were some patterns that were kind of linking up to areas of prostate cancer after the prostate was taken out. And one of the patterns here I'm going to show you, these are two men with repeated negative biopsies. These guys that had 30, 40, 50 cores taken over 2 or 3 or 4 attempts with their PSAs keep going up. They both had PSAs over 10. And what you'll see is that these sort of smudged areas, and I'm a radiologist, to me, I'll tell you, they're easy to see, but trust me, there are a couple of smudged areas there, and it looks like I took my finger on a charcoal painting or charcoal drawing and I smudged it out. And these cancers...
Is this an MRI picture?
Yes. Yes. So these are 2 MRI pictures, and they're showing these smudged out areas. We put needles right into those areas and found large cancers. Both men went immediately to treatment. These would not have been found for a long, long time if we hadn't seen these on imaging. So this started a lot of discussion around whether we could use MRI to find cancers. This is a second patient, and this represents the state of the art. And we were fortunate, our group, to be part of this discovery. There's a type of MR called diffusion-weighted imaging, and it's actually used for stroke. It was really first used, and it's actually available on just about every MR scanner out there, where any hospital where they're doing stroke patients. But we started to apply it in prostate. And what we found is that the same type of MR imaging that can detect stroke in the brain actually can help find cancer. And it's this white stuff. It actually jumps out at you as a white area on this type of imaging. And this is, the patient had their prostate out, and this area is exactly where the cancer was. Well, that's starting to look pretty good, that we can start to find these cancers. And in fact, what now our group and multiple groups have shown is that we can actually find these cancers with about an 85% accuracy, clinically significant cancers. So we're missing very, very few of them, and we can start to follow these and see these on imaging. So this is very exciting. And so there's the cancer again, this white area here. You can see it's a little dark on this type of MRI image. And this is in the peripheral, like you notice that there's sort of this mustache part on the outside, and there's this bubbly part in the middle. This is where a lot of the needles go for the biopsy, in this mustache sort of part on the outside. About 70% of cancers are there. And we can certainly see this one really, really well. So in fact, things have really progressed. And we now have international consortiums and standard sets. So this is the latest, something called PIRAD. So I don't know if any of you or your spouses have had, your partners have had a mammogram, but the report that comes back with what's called a BIRADS number. So there's something called a PIRADS number. It's a number from 1 to 5, which actually we score each lesion we see in the prostate. So if you're looking at a prostate MRI report, look for a scale of 1 to 5 in the report. If you don't see it, whoever's reporting it is not up to date on what they should be doing, and you should have some questions about the quality of the MR report. This is the standard. The American College of Radiology, the European Society of Urogenital Radiology has put this together. I'm part of this committee. This is round 2, so we're quite advanced. 5-point scale, PIRADS. And 5 is the worst. 4 is still pretty bad. If you have one of these two, you need a directed biopsy. If you have 1 to 3, it's at the discretion of you and your urologist what you're going to do. So now we can start to talk about, well, how are we going to get the needles in to the prostate? How are we going to actually get our needle to the cancer? And the obvious approach, and the first thing to do is, well, let's do the biopsy in the MRI scanner. And there are tools to do this. Very few centers in the country have these. We're purchasing one, and we should have it next year. And this involves actually putting a small tube into the rectum. It's a little bit smaller than the size of the ultrasound probe that you may have had your biopsy with. And I don't know if you can see it, but there's a needle actually in here. There's a dark line here. Probably can't see it very well, but there's a needle right there that's going right into the tumor that we saw in MR. So that's one way to do it. The problem with this is you can imagine all of you who have had an MR for any reason in Ontario know how long you've had to wait for that knee MR or back MR or head MR. If we start doing all of these biopsies in the MR scanner, we're not going to have time to scan patients for what they need to be scanned for. We don't have enough MR resource to do this. In fact, very few countries do. Even the Americans aren't going this way. This is too expensive. So we need an alternative and reserve this only for the most difficult cases. And this is where what we call truss MRI fusion comes in. This is where we take an ultrasound and an MR and we merge them together, and we use tracking devices so we can superimpose the MR on the ultrasound. So this involves a standard ultrasound machine, a tracking device, and some software that allows us to merge the MR images and the ultrasound images in real time. So as the urologist or radiologist is moving that ultrasound probe around to do the biopsy, he or she can see the MR image with the tumor dot right there moving around with that so that they know exactly where to put the needle. So this is what happens, is that a radiologist will trace the prostate and trace where the tumor is, and this is an MR image superimposed on an ultrasound image, and this is what the operator will see who's doing the ultrasound biopsy and can start to direct the needle right in there. Oops. Okay, so I'm going to just move out from behind the podium here and play this video on the right side. And this is actually Laurent Milot. He's one of the doctors at Sunnybrook who leads a team that does these fusion biopsies. And what I've done here is I've traced the prostate, I've traced where the tumor is. This is actually images from this fusion system, and we can actually see where the needles went right into the tumor. And I'm just going to play this video, but this is the fusion software. This is the ultrasound image that he's looking at. And let's see if I can play this. So you can see here as he moves through the prostate, the MR image is moving over here, and he can watch these and put these two together. And the machine will actually set up the direction of the needle so that it goes right through the tumor. And when he fires the gun, it's going right through the tumor. So we do these routinely at Sunnybrook. We have one session a week where we do these, where him and his team do these biopsies. They're pretty fast now, and we're looking to expand this service. So this is how we're doing the majority of our biopsies now, and we're not really focusing on the MR, and we're doing very well. Like we're able to hit these tumors very well with this technique. So that's what we're doing, how we're getting at the tumors. There have been now multiple publications. This is the largest one. This was published out of the National Institute of Health in the United States with over 1,000 patients, showing that we can detect with fusion. This is a fusion biopsy study with MRI and ultrasound fused, showing that we can do a very good job of picking up like close to 80% sensitivity for whole mounts. And one of the key things about for clinically significant cancer, when we look at prostates that are out. But what I really want to point out here is that we're increasing our detection of clinically significant cancer by almost 30% at the biopsy. And we're decreasing our detection, which is a good thing, of clinically insignificant cancer by close to 20%. So we really are segregating out and only biopsying and finding the cancers we want to find, while not finding a lot of this cancer that we really don't care about. And so this is published in JAMA, which is one of the top-level journals, and really has been instrumental in wide adoption of this. This is a study we did here at Sunnybrook in active surveillance, again showing that the PIRADS 4 and 5 lesions really match up to the presence of clinically significant cancer. So this technique works. And I'll show you some examples now and tell you some stories about patients. So here we have a patient. This is like a lot of patients who are first adopters. This one's a physician. And he's a great golfer and good health. Nothing's wrong with him. But his brother developed prostate cancer at the age of 60. he was quite worried about prostate cancer. His PSA was not high, actually. It was only 2.3. But he said, you know what? I'm worried because my brother had prostate cancer. And he had this MR done. Remember I showed you that bright spot? So this is one of those diffusion scans. And there's a little bright spot right here. And it's so tiny, I wasn't too worried about it. I said, you know what? Let's just watch. This is too small to do anything about. So 18 months later, he comes back. And his PSA is 2.6. Hasn't really changed very much, still under 4. But this is starting to look a little bit more worrisome. But it's still tiny. Like, just to give you an idea, that's about 2 millimeters. It's really small. Again, let's just watch. He comes back again at 2 years. PSA is now 4. And this has now gotten a little bit bigger, a little bit brighter. I said, okay, well, we should do a targeted biopsy. And Laurent did the biopsy, took a few cores through here, came back as Gleason 8 cancer. And he went on to have his prostatectomy. He's doing fine. He decided he wanted a prostatectomy because he said, I don't want to take any chances. I want this out. And he's doing fine. And our goal here in this whole process is to catch the cancer before it takes off, before it spreads outside the prostate or does anything bad. And now that we have the window of imaging, we have the potential opportunity to do this. Here's another case, and you know, I'm probably going to be one of these bad patients where I just hate the idea of having anything done to me. I'm just I try to be a good doctor, but if I think when you put an IV in me, I pass out. Like I just can't take it. So it's easy to stand here and talk about everything, but harder to be a patient. But here's a patient who had a prostate cancer. It's right there, this round thing, and I'm worried about it. It's up almost 7 or 8 millimeters in size. I said he needs to have a directed biopsy and he needs to have treatment. Patient said, I don't want anything done. And there are sometimes very good reasons. There's other things going on in life. There's comorbidities. Maybe he had bad heart disease, something else where they just decided not to. Came back 29 months later. Its PSA's gone from 13 to 25. And sure enough, you can see the cancer's brighter and bigger. It's now spread outside the prostate. And this is an example where we've kind of missed the boat on this one. We've gone a little late. And his prognosis, his overall chances of survival in prostate cancer have significantly diminished because it's gone outside the gland. Remember I told you if it goes outside, it's a bad prognostic. But we have a window into the imaging. With the imaging, we have a window. So I'm showing you all this stuff and say, well, geez, you know, we don't have access to all of this. We didn't have access to all of this. What are we doing? So we're moving the whole community is moving as fast as we can to do research studies. So we can build the evidence for healthcare systems to decide how they're going to fund this, and that there's enough evidence to fund it. Every dollar we put into this the way the economy is and the way the healthcare system is a dollar we take out of something else in healthcare. So we got to be careful that we don't start buying MRIs and doing thousands and thousands of scans only to find that we've sort of traded off this disease and these issues for something more serious and hurt the overall population. So this is the economics of it. So we need to do studies. And we are doing a screening study, and this is where if your PSA is above 4, we do MRI. This is a study sponsored by the Prostate Cancer Canada and the Ontario Institute of Cancer Research. It's called the PRECISE study. We're just getting the sites together now. We're hoping to open this study at multiple centers across Canada in the next few months. And we're going to see if we can really reduce the number of biopsies that need to be done. So you have a high PSA, we get an MR. If your MR is normal, PIRAD score less than 3, you don't even get a biopsy. And we're going to have another arm where you do get a biopsy and we're going to compare. So that's one study that's happening. In some countries, they're just doing this without a study. Next study that's happening is and this is one that's happening at Sunnybrook, and we're opening this study this year. You may actually see an ad in the paper about this study. This study, we're not even worrying about the PSA. And this one is a true screening study. Just like that first case I showed you where the PSA was less than 4 and we found a cancer. and we watched it. The idea here is to say, well, what about the men who have prostate cancer with PSAs less than 4? How many are there? Can we catch them? And maybe if PSA is not a good test, we should be doing MR. So we actually designed a special MR protocol where you're on and off the scanner in 20 minutes, no injection of anything, and we just get you on and off of there for a quick scan. So let's look at some more cases, and this case is very personal to me. This is my father. And he started with a PSA in the 2 range, and within 2 years it had crept up to 4. And he's in his early 70s at this time and in perfect health. And 70s is exactly the age where the surgeons become less and less likely to operate on you as you get into your mid and higher 70s. You're more likely to get radiation. And so this was the window. I said, okay, well, let's look. And to my dismay, I found a cancer. It's right here. It's about 5 millimeters in size. It's right there. And we did a directed biopsy, and we found Gleason 7 cancer, and I had a long discussion with the urologist. I backed off, but I said, look, these are his results. And he went on to have a robotic radical prostatectomy. He's very happy. His PSA 0. He's 5 years out now. He's fine. This is a true screening type scenario, and this was done on a research protocol. So I don't know if I truly helped my father or not. I hope I did. I hope he didn't get operated on when he didn't need to be operated on, but he's happy. I think I did the right thing, but I truly don't know because we don't have all the studies done. And this is the conundrum of the new technologies, but it is a story for you, and I do think that this is the future of prostate cancer. Look at this location. For the next 6-7 years, as his PSA went up with the standard biopsy approach, they would have never found this. It's so far in the front of the gland. Okay, I won't go through this for the sake of time. I want to now quickly touch on a couple of other scenarios. Let's say you've been diagnosed with prostate cancer and your surgeon's about to operate or your radiation oncologist is about to treat. Some surgeons and radiation oncologists are modifying their approaches to surgery and radiation based on the MR. And so I'll give you an example. Here's a cancer, and I've got the orange arrows on it. It's gone outside the prostate. That doesn't mean you can't have surgery. There are many surgeons that will still operate. What they will do is they'll do a nerve-sparing operation on one side to help try and preserve potency and continence. And they will do a wide excision here to make sure they get all the tumor. So they'll use the imaging to help direct the surgery. Now, in some cases, the tumor is spread so far out that the surgeon will decide based on the imaging to not operate and that you should have radiation and hormones. So there are some surgeons using this. It's not universal, and there's some surgeons like it, some don't. But here's another example, again, where the tumor has spread outside the gland, and the surgeon may elect to not do nerve sparing on this side, excise widely, and spare the nerves in what we call the neurovascular bundle back here. I don't know if any of you have had your prostate out, but you may have heard of nerve sparing surgery. So let's get real. Let's talk about Ontario and the healthcare system and where we are. This was yesterday from the public website on the current wait times for MRI in Ontario. And this actually doesn't include some of the major teaching hospitals. And it's already in the 3-month range. I am booking prostate MRs into early 2017 right now. So how are we going to deal with this? And I don't have an answer for you. I'm putting it forward because advocacy would be a good thing. And the community having more knowledge about this would be a good thing. But what we have done, and what I have tried to do as a physician, is work with Cancer Care Ontario on reviewing the evidence and establishing some guidelines for Ontario. So we are one of the first provinces to have guidelines that include MRI. And what we have is that for screening before PSA, there's still not enough evidence. For PSA greater than 4 before biopsy, there's still not enough evidence, so we don't recommend it because we'll break the bank on the healthcare system if we open this. There are trials happening, but not for standard of care. PSA worsening and prior negative biopsy. This is, and these are soft recommendations, they're not mandatory, but your urologist may elect to do this if they've got access to radiologists and MRs where this can be read. and we are doing this for many patients. Low-risk cancer on active surveillance, only if the PSA is rising. In other words, your risk profile is worsening on active surveillance. Again, may be done. If intermediate or high-risk cancer, may be done for staging. That's where you look for it going outside the prostate. And if the cancer comes back, and I'll show you an example of that, after you've had your radiation or your surgery, there are some indications for that as well. So these guidelines are out for your doctors on the websites on Cancer Care Ontario. You can actually access some of these as well. So what's going to happen if you have a prostate MR? What are you going to go through? Well, rectal gas is really bad for prostate MR. So I have become an expert on enemas, suppositories, gas control, stuff they never tell you in medical school how to deal with this. So we all have our own recipes, I guess, but you're going to get mine if you come the MR. So often what we tell patients is, look, you know what gives you a lot of gas? Don't eat foods like that the day of your MR or the night before. Don't chew gum, because that'll put a lot of gas into your bowel. If you're constipated, we want you to do an enema, a fleet enema, before you come to the hospital and have your MR. If you're not constipated, try a suppository or something a little milder. A glycerin suppository is probably the mildest. So we want some sort of bowel prep so that there's really no gas. If you got gas in your rectum, the images are going to be really bad and hard to interpret. We want you to empty your bladder before getting on the magnet so you don't have to pee. If you got a hip prosthesis, we're working on this, but it really messes up the imaging, and this is a real problem right now for MR. You can still actually have an MR if you have a hip prosthesis, but prostate MR in particular gets messed up with this. So we're working on this. Cardiac pacemakers are a problem still. Claustrophobia, a lot of the new magnets are going, and we're getting 4 new magnets at Sunnybrook next year. We have a larger bore, it's 70 centimeters, but the older ones are 60, and it is kind of tight. So, you may want to get pre-medicated with something, a mild sedative. We can't sedate you. You can't go to sleep. And the exam's 30 minutes to 1 hour. There is something called the endorectal coil. And this goes back to the 80s, the 90s. And this was back when MRs weren't as powerful as they are now. And this is a big balloon. There are many centers, particularly in the US, that still use this. I will just tell you quickly that you don't need to have this to get a good prostate MR anymore. And this is, we have different MRI field strengths. We have 1.5 Tesla, 3 Tesla. A 3 Tesla MR, 3T, without an endorectal coil is good enough. And there's a little bit of controversy about this, but I think the whole world is going this way. We don't want to deal with that endorectal coil. We don't want to put our patients through that. The whole point is to make the quality of life around the diagnosis better. And so we don't want to stick those big balloons in. Now I'm going to show you and finish off with some advanced stuff. So this is stuff that really was pioneered at Sunnybrook. And it turns out, and there's lots of ways of treating prostate cancer. You can take the prostate out, you can give it radiation, and you can be very careful with the radiation, use all kinds of new machinery and little radioactive seeds to be very precise about the radiation. There's been a lot of advancements to try and reduce the side effects in those 2 fields, and you'll hear about them if you go to a center that treats prostate cancer and you have prostate cancer. But with MRI, we can do an ultrasound combined. We can do 2 things. Now, ultrasound, I've showed you how we can make diagnoses with prostate cancer and see the prostate. So one way we use ultrasound, and if you've had an ultrasound, you know what I mean, is to look inside the body at various things. Another way we can use ultrasound is to actually heat things. So you can actually use ultrasound to heat things, and you can heat them to a point where you cook them, you kill them. And we got to get to 55 degrees Celsius to do that. And so a device was invented by a medical biophysics group at Sunnybrook. It goes into your urethra, so we don't have to go into the prostate gland. This is all done under anesthesia, so no pain for the patient. And these are ultrasound, there's a little ultrasound crystal embedded in here that can deliver ultrasound energy. Now imagine that we can do this. We can actually control the amount of energy, and we can control the rate that we can rotate this device in the urethra. We now can do a little video game where I trace the prostate, and I know where that ultrasound is pointing, And by changing the speed and energy at which I rotate, I can actually burn a sector of the prostate very precisely. And I'll show you a video of this. So this is the setup. We've already done some studies in this. We did the first in-human study in this. The publication's coming out soon, and there's a large multi-center trial that's starting on this in prostate cancer patients. So this is the setup. This patient is anesthetized, so I know it looks a little gruesome, but this isn't surgery. After this is done, the catheter comes out of the urethra, you're done with your treatment, and the side effects are minimal. So with this focal approach. So here I am at the console planning where I want to treat. And remember I showed you this cancer here? This was actually a patient on that study. And he was a very altruistic patient. He agreed to say, this study was a tough study for patients. I actually have a great deal of respect for the patients that agreed. What they agreed to is, you can treat part of my prostate and then you can take it out. So you can match up and show that you killed the cancer. You really killed it right to the edge. These are very special patients, and I certainly owe this patient and all the patients a debt of gratitude. But what I want to show you is that we actually burned this area of the cancer. And let me show you what that treatment looked like. So this is a video. What we have here is we trace the prostate. This is this round circle. This is like a bread slice through the prostate. Each one of these is a bread slice through a different location. This is a vertical slice, like a coronal slice like that. You can see the probe in the prostate itself. That's in the urethra, okay? And these are like bread slice images through the prostate. And remember, the tumor was over here, and I've mapped out where I want to kill the tumor. And now I'm going to play the video, and what you're going to see is the temperature. You're actually going to see remember I told you MR can measure temperature, and you're going to see the probe rotate and burn this sector of the tumor. And we got the whole tumor in this patient. There's a clock here that will start, which will show you how long it takes. And this procedure is actually pretty fast, less than 20 minutes. So let me get this going. So there it goes. It's sped up a little bit, so you can see the time. See that? It's heating up. And it's going to start to turn now and rotate. And it's just burning a sector of the prostate. Patient's lying in the MRI scanner, sedated. And we're just cooking this corner of the gland. After this, we're going to take the probe out. It's done. So now in radiation, this is what we call focal therapy. And the idea is to start to think about this like they started to when they revolutionized breast cancer treatment, right? So in breast cancer, women were going through in the 60s and 70s radical mastectomy. The whole breast was coming out. In many cases, the muscle was coming out. Very aggressive surgery. We're doing the same for men. We're taking the whole prostate out. What if we can do focal therapy? And so this is called people coin this the male lumpectomy. And the idea is that we do this, and then we keep watching with MR. The only way you can do this is if you got good imaging and a good blood test like PSA to follow after this treatment. So if a new cancer comes up, because you still got prostate tissue there that you can catch it. So there's a lot of research going on all over the world. If you look this up, focal therapy of prostate cancer, you will find studies everywhere. Every major developed country has got a study on this if they're involved with prostate cancer. But I wanted to show you this as exciting technology. It's not mainstream yet. There are various flavors of this happening, this male lumpectomy or focal therapy or focal dose escalation enabled by imaging happening in radiation therapy and various forms of surgery. I'm going to finish off with 2 slides for the patient who has further along in their cancer story. And this is a patient who had external beam radiation therapy for prostate cancer, and it's come back. And the term that's used for dealing with this is called salvage therapy. And if there's no cancer anywhere else, and it just come back in the prostate, and we have a way of detecting this with MR, the radiation therapists and the surgeons can actually go in and we can do the same thing. We can either focally treat the area of recurrence. If we treat the whole gland again with radiation, there's a lot of complications. It takes the surgeon can go in and take the whole prostate out, but the complication rate is quite high of developing fistulas and other bad things if you've had radiation. But there are some very skilled surgeons who can do that as well. But certainly knowing exactly where the recurrence is and knowing what region of the prostate to retreat will limit the side effects and complications. So there's a lot of activity in this. And the last thing I'm really excited about for those patients with advanced prostate cancer is this is not MRI now, although there is work going on with fusion of MRI in this. And this is a type of PET scan. So when, I don't know how many of you have heard about PET scans. PET scan is a type of nuclear medicine scan, but what maybe many of you don't realize is that there's actually, a PET scan is just, the PET scanner itself stands for positron emission tomography. What's actually important, very important as part of this, is what agent you inject. So up until now, they've been injecting a form of glucose called FDG. And it turns out that cancer loves sugar. And so the reason why PET scanning is used in certain types of cancer like lung cancer is because lung cancers just eat up the sugar. And when we do a PET scan and we've injected this radioactive sugar, it just shows up like a light bulb where the cancer is because it's gobbled it all up, while the other tissues aren't eating as much sugar. And so, in fact, if you're diabetic, or they'll tell you not to eat sugary stuff and other things before you have your PET scan. So that's a typical PET scan, but you can actually inject other agents. And there's been a really exciting development in prostate cancer with an injectable agent called PSMA, prostate surface membrane antigen. And it's actually quite specific and sensitive for prostate cancer. And there's been some tweak to the pharmacy of this to a point where with this technique, they're able to start to detect really tiny, this is a tiny lymph node. All these arrows are pointing to tiny metastasis. So there's two different patients. This patient on the left has a prostate cancer. Now the surgeon knows that there are these little tiny positive lymph nodes. These are not lymph nodes I can see with a standard CT scan. And now the question is, if the surgeon goes and takes these lymph nodes out at the time of radical prostatectomy when they're removing the prostate, will this patient have a better outcome? Because normally they wouldn't have taken them out because they're so tiny, they wouldn't have come on anyone's radar. So there's a lot of work happening now in what we call better staging of prostate cancer to see if either radiation combined with surgery in these higher risk cases will reduce the recurrence rate where patients come back 2 or 3 years later with their PSA elevated after surgery. So this is an exciting development. This is not an approved agent or test in Canada for clinical use. The only countries that I'm aware of there are some countries in Europe that are providing this. You can go pay for it. Australia seems to be doing a lot of these. I think this will come to Canada eventually. It's just looking so good. This is a more advanced case where small bone metastases were picked up. So there's a lot of interest in the surgical and radiation therapy community and medical oncology community about how to use this new information. But this is really exciting, it's new. And I'm going to stop with that, and thank you very much for your attention. I know it was a lot of stuff, but I hope you share my excitement in some of these developments.